as diabetics, transplant patients, steroid users, and HIV-positive patients. I also have a low threshold for admitting those patients as well as those with ascending lymphangitis. Early infections can be treated non-operatively with oral or IV antibiotics, but most present as surgical emergencies needing operative drainage to prevent tissue loss and ascending infection. A felon is an abscess in the fingertip pulp. The patient will present with a swollen, tender, throbbing volar fingertip. There is frequently a history of a penetrating injury, such as a splinter or thorn. The treatment for an abscess is surgical drainage. This is a procedure that is easily performed in the emergency room under a digital tourniquet and a digital block. The abscess can be incised directly over the pointing region, or an incision can be made over the ulnar side of the index, middle, and ring fingers, or the radial side of the thumb and small finger. Make sure you get down to the distal phalanx and include all of the involved septal compartments. Wash out the wound with a combination of betadine and normal saline and pack it with a 1/4-inch iodoform gauze. Obtain a culture and prescribe a 7-day course of a broad-spectrum antibiotic. Refer the patient to a hand surgeon for follow-up within the next 24 to 48 hours. Be aware that herpetic whitlow has been known to mimic a felon. The classic presentation is in children and medical or dental workers who are in frequent contact with saliva. They present as painful small vesicles. This is a self-limited problem and should not be opened due to the risk of secondary infection. A paronychia is an infection of the epinechial fold. The etiology is often a hangnail, manicure instrument, or nail biting. Early on, it can be treated with rest, oral antibiotics, and soap and water soaks. Once an abscess develops, it needs to be drained. This can be accomplished with an incision where the abscess most closely approaches the surface. Direct the blade away from the nail to reduce the risk of injury to the matrix. Part of the nail plate may need to be removed under a digital tourniquet and digital block. Drain the abscess, send cultures, pack the wound if possible, prescribe a 10-day course of oral antibiotics, and refer to a hand surgeon within 24 to 48 hours. Flexor tenosynovitis is something that will need an immediate referral to the hand surgeon because it is an abscess of the flexor sheath that needs to be drained in the OR and admitted for IV antibiotics. Be aware of the 4 Cannavale sign. Number 1, uniform, symmetric, sausage-like swelling to the digits. Number 2, flexor sheath tenderness. The flexor sheath runs from the distal palmar crease to the distal finger crease. Number 3, a semi-flexed position of the finger. And number 4, painful passive extension. There is frequently a history of a small puncture wound into the flexor sheath. Dorsal finger abscesses can usually be drained in the ER under digital anesthesia and a digital or forearm tourniquet. Remember to culture the abscess, pack the wound, and refer to the hand surgeon for urgent follow-up within 48 hours. Hand abscesses and the infamous clenched fist injury, when a patient strikes the mouth of another person, will usually need drainage in the operating room at admission for IV antibiotics. If a patient gives a history of recently punching someone in the mouth as the etiology of a break in skin, be suspicious of a more serious problem. The tract will need to be opened and washed out. It may involve skin, subcutaneous tissue, tendon, joint capsule, and bone. A metacarpal phalangeal joint infection will present with passive, painful motion to the joint. A real time-dependent emergency is compartment syndrome. This interstitial pressure becomes too great for the confined space, which restricts oxygen perfusion and leads to muscle death. Common presentations are crush injury, casts and dressings that are too tight, snake bites, spontaneous bleeding, electrical and thermal injury, displaced fractures, and reperfusion injury. The patient will have a painful swollen hand and pain on passive digital motion. If the compartment syndrome is in the volar forearm, there will be painful passive digital extension. If the hand is involved, the patient will have pain to passive abduction and adduction of the digits. When in doubt, you can get objective numbers with a striker or an A-line transducer. The threshold for surgery is greater than 30 millimeters of mercury or 20 millimeters of mercury below diastolic pressure in a hypotensive patient. The patient will also complain of reduced sensation and weakness in the extremity. Be aware that the pulses are last to go. Surgical treatment should not be based on the absence or presence of pulses. There is a 6 to 8 hour window before muscles start to die and the nerves suffer irreparable damage. This is a situation that needs a direct discussion with the accepting hand surgeon if you need to transfer the patient to another facility. The last thing you want to do is transfer a patient to a busy trauma center where there is a several-hour wait for an OR to become available. Injuries from temperature extremes is covered in another DVD. The points you want to remember is that those patients will need to be referred to a burn unit or to a hand surgeon. Electrical injuries will need admission to a burn unit. They can present as small injuries, but there may be significant underlying damage to the muscles that is not immediately visible on exam. They will have to be admitted for serial exams, possible fasciotomies, and electrolyte monitoring. Fingertip injuries are extremely common ER walk-ins. The goal is to preserve function, preserve length, decrease pain, maintain mobility, minimize downtime, and maintain aesthetics if possible. The first thing you want to determine is the extent of injury. Is bone exposed, tendon exposed? How large is the soft tissue deficit? Is the distal phalanx fractured? Commonly, a patient will have a crush injury to the fingertip involving the sterile matrix. That is the region just under the fingernail. A painful, throbbing, small subungual hematoma can usually be drained with an ophthalmic cautery. In general, if the hematoma involves greater than 50% of the sterile matrix, most likely the laceration needs to be repaired and the nail plate needs to be removed. Prep the hand with surgical soap. Antibiotics are appropriate if there is a significant amount of contamination or if the patient is immunocompromised. Verify that tetanus is up to date. The fingernail will be removed under a digital block and a digital tourniquet. Clean the undersurface of the nail and soak it in betadine. Irrigate the sterile matrix with a combination of betadine and normal saline. Reapproximate the edges of the sterile matrix with a 5-0 or 6-0 fast-absorbing suture. Replace the nail plate into the eponychial fold to prevent adhesions and splint the fingertip. 50% of nail bed injuries will have an associated distal phalanx fracture. Refer to a hand surgeon for follow-up within 5 to 7 days. If your exam finds a soft tissue injury less than 1 centimeter and unexposed tendon or bone, gently wash the wound and cover with a non-adherent dressing, usually Zeroform or antibiotic-coated adaptic. Change the dressing PRN. Over 3 to 6 weeks, the wound will re-epithelialize and contract. Larger wounds without exposed tendon or bone can be covered with a full-thickness skin graft. A good donor site is the hypothenar region of the hand. This provides skin of a similar nature and is in the same operative field. Other donor sites are the inner arm, lateral big toe, and groin.